So does someone want to go first with the question? So the question is the VA program in Tucson still in existence to help train VAs who are vision impaired, correct? Is that basically your question? Who on the panel wants to take it?
I would say that it would be beneficial for you to contact the Southern Arizona Veterans Hospital. They do have a separate program for veterans who have vision deficits. Some of those are combat injuries, the sequelae from combat injuries. There are younger vets who are coming back, but the majority of the folks that they work with are the aging veterans who have macular degeneration, diabetic retinopathy, glaucoma, or a combination of that. They have a wonderful program out there.
So the program is in existence, you think, Renee? Mm-hmm. Okay. Okay. Dr. Noon, you want to comment?
Just want to add to that. You have to be entitled to services through the VA, and you have to be, quote, legally blind to be part of this program. The program can last up to a month or maybe 5-6 weeks, depending on what you need. But you can also see if you're eligible from the VA hospital here in Phoenix on 7th and Indian School. And Tom Hicks is part of the low vision department there, and he can help you decide if you're entitled to the service and get you involved in that program. So you don't have to go down to Tucson to see if you can get involved, okay? And it's Tom Hicks.
Okay, great. And we can write that down for you, sir, if you need us to. And it's an excellent question because I think everyone in this room will agree we need to take care of the wonderful folks who fight for us, fight for our freedoms. Okay, another question.
Is it possible for a person with dry turn into wet?
Okay, we're going to let Dr. Seathram take that, and also Dr. Noon, if you want to chime in as well.
Yeah, it is common. That's the most common way wet macular degeneration presents, meaning that somebody has precursors of dry macular degeneration. It's very rare for someone just to walk in with suddenly wet macular degeneration to never have anything before that. Now, if someone's not getting eye exams, they might not know that they have dry macular degeneration. There are some subsets of patients who do get the wet form without too many signs of the dry, and those patients tend to be those who are smokers, current smokers, or heavy smokers in the past.
Is there a test for that?
A test for the dry? So when we examine your eyes, we're always looking for that. So we'll look for signs of fluid or blood. And now, the standard of care is to do those OCT scans, the cross section where we cut into the retina and looked at it from the side. That definitely shows us whether fluid is building up in the retina, and that's the initial signs of wet macular degeneration. The other thing we can do is the dye test, the fluorescein angiogram, but that's a little bit invasive. There's not too much risk with that, but we put a little dye in the arm vein. That dye circulates in your retina. We can see what parts of the retina are leaking, if any. And so those two tests help us determine if it's dry or wet macular degeneration.
I really like the idea of the occupational therapy, and I was wondering if there was anything in the Mesa area that there's anybody that does anything like that.
Okay, anyone in the Mesa area that does the occupational therapy? Dr. Noon.
We had an occupational therapist part of our practice up until last Friday for 10 years, but she's gone on to bigger and better things, and I'm going to be looking for another occupational therapist because I think it's a wonderful part of my practice, and it's a needed part. So today we don't, but soon.
Okay, anyone? Oh, good, okay. We talked earlier.
I'm just wondering, what is the difference between a rehab specialist working with vision devices with Dr. Noon as opposed to an occupational therapist? Because I think most people who become visually impaired, I think they're going to do that. They have a rehab therapist, right?
Okay, so the question is, just paraphrasing, again, what is the difference between an OT and a rehab therapist? Okay. Renee's going to take that.
There are a multitude of people out there, of resources out there that work with, that are in low vision rehab. There are certified low vision therapists through a different agency. There are low vision therapists. There are low vision teachers. There are mobility specialists. There's just a plethora of resources out there. The OT, the background of an OT is basically you have a wealth of knowledge in all the physical deficits. If I work at a hospital, and so my primary job there is in inpatient rehab. What I first address are the physical deficits, the self-care deficits. And if vision comes into play, as it usually does in performing any of those kinds of things, or if physical deficits, traditionally of the upper body, lower body, walking, mobility, etc., the occupational therapist will address those along with the rest of the rehab team, which is the physical therapist, the speech therapist, the physiatrist. There's a great deal of, what am I trying to say here? The training, low vision is not particularly part of the training of an occupational therapist as you go through your program. Additionally, I took another course through the University of Alabama, and it is specific to low vision because there's such a need out there for therapists to work with low vision folks.
So believe it or not, I just want to add to that. When Renee and I first spoke, and I have experience in acute healthcare and lots of healthcare experience myself, and I couldn't believe that as an OT, vision wasn't taken into consideration. I mean, can you believe that? I mean, they were, again, not a criticism of the profession, but again, not an emphasis on vision with everything else that your body might need in terms of rehab, and again, learning to integrate back into, your daily routines. Something to think about. Okay. And we have one here. Who's first? You okay with that? I know what you want to ask, so we'll come to you for sure.
Is there anything on the horizon for a long-term cure for macular degeneration? I understand that in Israel, for instance, they have found a way to place a lens in the retina area that somehow halts the disease and also starts curing it. I don't know if you've heard about it, but I've been reading about it.
That was on the internet, that's right. You know what they say about the internet, right? No, I'll take that one, being the research person, but also if any of you have a comment on that, feel free. And from the foundation's point of view, what is really on the horizon? And again, this is a study that we are funding currently in Israel. And it's really genetic therapy. It's gene therapy. That's what's on the horizon as far as we're concerned in terms of what has the most promise to find a cure. Gene therapy is very different than the genetic testing. Okay, this is gene therapy, so in other words, that's figuring out what gene it is, either that you're missing or that's something wrong with it, and that's the way, and changing that. Okay, I'm kind of putting it in very simplified terms. But that's where we believe has the most promise for the cure. We also believe that stem cell research has a lot of promise in terms of leading to a cure as well. So, and I'll just add one more thing, and if you have a comment here, we convene a scientific conference every 15 months as part of our foundation portfolio. And we bring in, again, by invitation only, 24 of the top scientists in the world, and they meet for 3 days. And that meeting is where they, believe it or not, compare notes, because scientists don't necessarily like to do that. And I know that sounds silly, but again, it's their body of work, and they protect it. They don't want somebody else, stealing it necessarily. So it's a very unique situation that we create for them because they're all funded by the foundation and they all have a dialogue amongst themselves and share. And it's multidisciplinary. So I can tell you that for the very first time, we've invited 2 of the top specialists in the world on inflammation who are going to be part of the dialogue. Because there's some belief, obviously it's about inflammation. And so potentially there's some complementary work out there with inflammation that could affect the eye. So again, this is all very preliminary, but it's all very much a dialogue, and we bring all those folks together to have it. So the answer is, again, not to be evasive, but there is a cure around the corner. And we're working very quickly to get there. And it's accelerating. The research is moving quicker and quicker to find that cure. That is true. And we will see it. And I hesitate to say in our lifetime because we all have different lifetime spans. So I try not to say that. Do you want to comment? Anyone else?
I think the lens you might be talking about is it the Lipschitz lens? Do you recall that being the name of it? That's a lens similar to the implantable miniature telescope that is available in Israel and maybe even in Europe. And I think that's the lens that you can put in even after cataract surgery. It works in concert with your intraocular lens. Do you know that one, Lynn? Gene therapy, I know the foundation's doing a lot of work on gene therapy for macular degeneration, but it's really making strides for something called Leber's congenital amaurosis, which is a congenital condition. Yeah. And so I know the foundation has supported that work, and it's really, it's out of the University of Pennsylvania, and it's really quite remarkable what they've done for that.
Yes, I have to say, we were largely responsible for that discovery, so we're very happy about that. The other thing I would say about the Lipschitz, Dr. Seathram is correct. We do have an individual who's involved with us. He happens to be the founder of Jiffy Lube. Seriously. And he was, you might have seen him on the Brian Williams Nightly News. It was this lens. And we've been in conversations with him. And he actually is friends with Dr. Lipschitz, who basically invented the lens in Israel. And he has the lens in, and he's doing okay, but he's struggling again with how to train himself to use it. And one of his big beefs is, I'm happy to say publicly, is no one teaches you after you get something like that how to deal with it. And there's a lot of rehab that's involved in it. So that's kind of where he's putting his energy right now. So you might want to Google that too. He's been out there talking about it a lot. All right, I know this gentleman has a question here. We'll get right back to you, okay? Promise.
I think you just answered most of my questions. I think most of my questions was just answered through the last conversations there. I was wondering about this implant that goes in your eye. If there was anybody here that knew anybody that has one, what the benefits, what the drawbacks are. Dr. Moon was kind enough to give me some information of who does it here in the area. And I'm very interested in talking to somebody that's had it done. Thank you.
Okay, do we want to get Scott involved here?
So I would just tell you that, first of all, Dr. Noon is on the team of rehab specialists. She's the low vision optometrist that works with our doctors. There's 2 surgeons in town that do it. You go through a lot of pre-screening to see that you're a good candidate, make sure you'll benefit from it. There is I can give this to you, anybody that wants it. There's a group of RNs, registered nurses, that will speak to you and answer all of your questions, all of your caregivers, family questions, anything like that. And they'll be able to tell you top line if you would qualify, have you had both your cataracts removed? That's the most common drawback or, thing that would screen you out. Dr. Seathram is also one of our doctors that refers patients in. So that you can speak with, there's 2 good practitioners here, and then our team of RNs can help you answer all your family questions as well. It's real dependent on support from the family. And one last question. There is a group of ambassadors out there that actually have gotten it, and Mr. Heineman, the founder of Jiffy Lube, is one of our patients that can tell you about the ups and downs. And I think you'll hear from our group. It's a very fair, balanced presentation. These folks will tell you there is a lot of work involved. So.
Yeah. So it's, there's still, you know, areas that we just have to work on so we can get you. Okay, who is next?
I have a couple of suggestions. If your macular has turned wet, you make sure you see a retina specialist because they can treat you so that it stabilizes and doesn't get much worse. If I had taken the shots when it was experimental, I'd be driving now, but I'm not. And there's a lot of things that a lot of people don't seem to want to go to a specialist, but it's extremely important. And also in the office of the specialist, you'll find a pamphlet with a lot of information on the things that ladies were talking about, different departments that take care of rehabilitation, free. So next time you go, if you do go to your specialist's office, ask them for this pamphlet with all the information, okay?
Thank you for your comments, ma'am. Thank you.
Is there any value in acupuncture?
There's no proven correlation between acupuncture treatments or naturopathic treatments and macular degeneration. However, you know, acupuncture does have a certain amount of what you may call a placebo effect, but even more broadly, that just a beneficial effect on your health. So if it's something you're doing for other reasons and you're finding benefit, you know, mentally or in overall wellness, I don't think that can be underestimated. There is a component when you start losing vision of depression that can set in. So if you can do things to offset that or make yourself feel better in other ways, I think there's utility in doing acupuncture for those reasons. But scientifically, acupuncture will not change your macular degeneration.
Yes, mine is, I'm a retired school teacher. I was in a classroom about 7 years ago, and while I was attending a student, there were just bajillion floaters all over the place. And within 24 hours, I had a vitrectomy, and then had another one 3 months later. And as I was trying to understand, you know, why I lost my vision on my right eye, I understood that it wasn't caused by macular degeneration, diabetes, or a blow to the head, that basically it was just bad luck. And since then, you know, I've tried to cope with the situation. Then my question is, I understand that we don't have retina transplants yet. What makes it so far into the future, or what is so complex about a retina transplant that we're not there yet? And according to your research, how, you know, close to into the future are we to having a retina transplant?
Comment? Okay.
Back to your symptoms of the flashes and floaters, those are emergent symptoms, but yeah, you're right. Those are typically not symptoms related to macular degeneration. In terms of a retinal implant, you know, our optic nerve connects to our retina, and there are 1.2 million nerve fibers there. So to get something to line up with that many nerve fibers is, at this point, next to impossible. Now, when the lady had mentioned an implant in the eye, it made me think about retinal prostheses, which are now available. It's only available for retinitis pigmentosa at this point in time. It's called the Argus retinal implant, and it's a microchip that goes on your retina, and it collects the light, and it acts like the photoreceptors. And so there are things happening with technology out there. We're not quite there yet for macular degeneration, but we'll get there.
Okay, one last one, real quick.
This question's for Dr. Noon. Some years ago, I came to you and you examined me for my macular degeneration. You attached a special device to my eyes, that combined my peripheral vision into a central vision, which was really neat. Is that still available?
Well, I can't remember what we did, but yes, anything that was available then. Basically, what we're doing is making things bigger than the hole in your vision. We're not putting your periphery into the middle. We're making things bigger than the hole so that you don't notice that hole. But whatever we had back then, we still have. And it's better. Okay.
All right, folks, thank you very much for coming.